Hello, I am Dr. Nicola Clayton, a consultant dermatologist working in London with a specialist interest in hair and scalp disorders. Dandruff, which is also named pityriasis capitis, is a non-inflamed, scaly scalp condition that can be associated with itch. It is a very common problem. The spectrum of dandruff is difficult to define, but remembering that it is clinically non-inflammatory helps distinguish it from seborrheic dermatitis and other scaly conditions. Although not as common as dandruff, seborrheic dermatitis is reported to affect up to 5% of the population. It is an inflammatory dermatitis primarily affecting the scalp, but also areas rich in sebaceous glands such as the face and trunk. There are both infantile and adult forms, with presentation in infants occurring usually at less than 3 months of age and tends to resolve by 6 to 12 months. In adults, there is a male predominance, with a peak incidence in adolescence and then again in the 4th decade with a further peak in the 60s and 70s. There is often a family history of seborrheic dermatitis or psoriasis. Here you can see the thick, yellow, oily adherence scale of classic infantile seborrheic dermatitis, otherwise known as cradle cap. In adults, seborrheic dermatitis usually presents with a finer scale, often with clearly visible background erythema. What causes seborrheic dermatitis? We still do not fully understand what causes seborrheic dermatitis, but we do know there are a number of factors involved, and a key component is the role of Malassezia, a group of lipophilic yeasts that are naturally found on the skin. Some studies report their number are increased in seborrheic dermatitis, whilst others state the same levels are seen in both affected and non-affected individuals. Thus, an abnormal immune response is postulated, along with an individual's skin barrier function. Malassezia are also thought to help metabolize certain types of fats on the skin, changing them into irritating and inflammatory fatty acids that cause inflammation by activation of the alternative complement pathway. Factors that increase the risk of seborrheic dermatitis include stress, alcohol, heat, humidity, UV radiation, immunosuppression, Parkinson's disease, depression, and a number of chemotherapy drugs such as BRAF inhibitors, tyrosine kinase inhibitors, and 5-fluorouracil. Additionally, drugs that can cause a seborrheic dermatitis-like eruption include lithium, methyl-dopa, and cimetidine. In adult seborrheic dermatitis, background erythema is usually visible with overlying scale. The patient is likely to report that their scalp is itchy. More extensive disease tends to involve the postauricular crease, eyebrows, including the glabella area, and central chest. There is a spectrum of disease severity, with dandruff being considered the most mild form of seborrheic dermatitis, whereas moderate disease will have erythema and more prominent scale. The scalp is clearly inflamed with thicker yellow scale in severe disease. As with any other significantly inflamed skin disease, there is risk of secondary bacterial infection from areas of broken skin. The left image depicts facial seborrheic dermatitis with classic eyebrow involvement. The inflammation and scale can clearly be seen. The right image shows how the skin can become raised secondary to the inflammation, almost becoming plaque-like. It is important to be aware of other scalp conditions that can present with scale, erythema, and itch. Pityriasis omantiacea is characterized by thick, adherent yellow scale which encapsulates the hair shafts, binding down tufts of hair. This is a secondary phenomenon on the background of another inflammatory scalp disease such as seborrheic dermatitis, psoriasis, atopic dermatitis, and tinea capitis. The hairs easily pull away from the scalp when trying to remove the scale. Tinea capitis is an infection of the scalp hair follicles and the surrounding skin with a dermatophyte fungus, usually Microsporum and Trichophyton species. It commonly presents as focal areas of scale, but can easily develop into a carrion where the skin becomes swollen and boggy, often with pustules and associated hair loss. If it is not appropriately treated with oral antifungal therapy, the hair loss will be permanent. Clinically, eczema can be easily mistaken for seborrheic dermatitis, and a good history is essential as the individual is likely to have suffered with eczema elsewhere on the body, along with a personal or family history of atopy. Their scalp will be very itchy with evidence of excoriations, and if chronic, lichenification. Seborrheic dermatitis and other scalp conditions are itchy and are therefore scratched. The scratch marks can lead to secondary bacterial infection, most commonly caused by Staphylococcus aureus. The skin will ooze a yellow fluid which becomes crusted and the scalp becomes more painful. It is important not to miss, as antibiotic treatment might be required. Scalp psoriasis is another differential diagnosis, but in contrast to seborrheic dermatitis, the affected areas are usually well demarcated with erythematous plaques and overlying silvery scale. Often there is ear involvement extending into the ear canal. Although contact dermatitis clinically can present with erythema, crusting and itch, the history is quite different. It is an acute allergic reaction following exposure to an allergen up to 48 hours before. For the scalp, the most common trigger is paraphenylene diamine, a chemical widely used as a permanent hair dye. In severe cases, the skin will blister, ooze, and develop crusts. Often there is accompanying facial involvement with eye swelling. Taking a good history is paramount. It is also worth mentioning pityriasis versicolor. This is a common rash consisting of discoloured, scaly patches predominantly affecting the trunk, also caused by malassezia. Malassezia can produce pigment but can also cause hypopigmentation by diffusing into the epidermis and impairing melanocyte function. Additionally, in some individuals, the malassezia will cause irritation, making the skin appear red. So how do we treat these scaly scalps? The mainstay of treatment is shampoo. A variety are available to treat dandruff and seborrheic dermatitis, and these are designed to be left on for 3 to 5 minutes in order for the active ingredient to be effective before washing out. I consider antifungal shampoos such as Ketoconazole as being first line, but it is important to take into consideration what a patient has already tried and additional factors such as the thickness of the scale, secondary infection, and inflammation. Thicker scale will benefit from a keratolytic, and an antibacterial shampoo is necessary for those susceptible to secondary bacterial infection. As the scalp condition improves, the frequency of use can be reduced. In stubborn cases, rotating shampoos with different ingredients can be helpful. Another treatment that can be offered is tea tree oil shampoo. A 2002 study of 126 individuals with dandruff who used a 5% tea tree oil shampoo showed a 41% improvement in severity, with less itching and scalp oiliness after 4 weeks, compared with 11% in the placebo group. Topical steroid certainly has a role to reduce inflammation and itch. It is important to consider the delivery method according to hair type, as some formulations will be easier to apply than others. It is important to explain that the topical steroid should be weaned off rather than stopped abruptly, as this is likely to cause a rebound flare. Returning to my severity slide, I usually recommend an antifungal shampoo such as Ketoconazole shampoo as my first line treatment for 4 weeks, reducing on improvement. But I might also advise a urea shampoo to not only help reduce the scale and itch, but to offer hydration, as dryness is a common complaint from Ketoconazole alone. For moderate seborrheic dermatitis, in addition to an antifungal shampoo, I would usually prescribe a topical steroid scalp application, often one containing salicylic acid. For severe disease, topical steroid is essential along with a keratolytic, and in addition to antifungal therapy, I am mindful to consider antibacterial cover if the skin is broken. I do come across challenging cases which appear unresponsive to conventional treatments and may require oral therapy. Common prescribed regimens include itraconazole 200 mg daily for 1 week, which can then be pulsed for 2 days per month for the following 2 to 3 months to prevent recurrence. This can be extended to 12 months if effective. An alternative is fluconazole. In summary, I have described the presentations of both dandruff and seborrheic dermatitis. Unlike dandruff, seborrheic dermatitis should be considered an inflammatory scalp condition, and although we are yet to fully understand the pathophysiology, we know that the yeast malassezia plays a key role in triggering an inflammatory reaction in the skin. I have highlighted the key differential diagnoses to aid successful diagnosis to help direct patients to appropriate treatments. The mainstay of treatment is antifungal shampoo, but after a treatment course, long-term maintenance may be required. Some patients will benefit from rotating shampoos with different active ingredients. Topical steroids have a role to treat inflammation and itch, and sometimes oral antifungals are required for recalcitrant cases. As a dermatologist, most patients have already sought advice from their GP or pharmacist, thus my advice will be tailored according to what they have already tried and according to how thick the scale is and whether there is active inflammation. That being said, for simple, previously untreated dandruff, I often recommend ketoconazole, selenium sulfide, or a coal tar shampoo. Studies show that they are similarly effective, but the side effect profile of selenium sulfide is slightly less favourable, often causing an oily scalp, or conversely a dry scalp, scalp irritation, or hair discoloration. If one appears less effective for a patient, then I will suggest the other. Many patients do report that ketoconazole shampoo causes their hair and sometimes scalp to be dry. I find that alternating with a urea-based shampoo, which is descaling, anti-itch and hydrating, can be helpful. Likewise, using conditioner on the length of the hair improves hydration. As shampoo is a rinse-off product, it needs to be left on the scalp for the recommended time period, so the active ingredients can work on the malassezia and scale, otherwise it will not be effective. I usually recommend a 5-minute application as I think it is easy to underestimate time. For pityriasis versicolor, it can be used directly on the skin like a shower gel, again leaving on for 5 minutes before washing off. I do believe that some people's dandruff or seborrheic dermatitis can develop tolerance to anti-dandruff shampoos that were previously effective. I find in this situation, the rotation of shampoos with active ingredients can be really helpful. Some patients have 2 or 3 different shampoos which they rotate every wash, whereas others find it beneficial to change every few weeks. I have not experienced an azole-resistant case to my knowledge, but I appreciate that this is an emerging concern. Reviewing the literature, most studies are in canines, and I have not discovered any papers specific to topical ketoconazole shampoo use for seborrheic dermatitis in humans. As for other active ingredients, a 2009 study investigated whether tachyphylaxis to pyrithione zinc-based shampoo occurs in long-term treatment of seborrheic dermatitis and dandruff. It concluded there was no evidence for tachyphylaxis in the treatment of these conditions.